Hello guys, today I'm going to talk about the gastric cancer. The gastric cancer, first of all, about the staging, the TNM staging. For this, I'm going to use the PET-CT, better than the CECT. Okay, and for it is more accurate for the metastasis than nodal staging, and then our tumor depth or size or depth, anything. It is basically depth, in fact. Okay, and for the nodal and depth, for the more accurate is our endoscopy. Okay, now the gastric cancer classification, I was telling about the TIS, T1A, T1B, T2, T3, and T4A and T4B. Okay, so TIS, in this we have the high grade dysplasia, and in T1A and T1B, T1A it is muscularis mucosa, submucosa, and T2 is muscularis propria. So from 2 it is the propria, okay, and from 3 it is adventitia, and then it is adjacent structure. 4 is adjacent structure, which is diaphragm and pericardium. Okay, and T4B is unresectable adjacent structure. So here till T1A, T1B, that is till submucosa, if it doesn't matter whether it is associated with nodes or not, till submucosa level we are going to call it as the early gastric cancer. And for this we have a Japanese classification. Okay, and for the later one we have muscle involving, that is serosa involving this is the late gastric CA, which is the most risk of vascular invasion. And in late gastric CA we have Bowman's classification. In Bowman's classification, I'm going to tell you about the polypoidal one. The first is the polypoidal one. Okay, so the one is polypoidal, and the 2 is ulcerative with a well-defined margin. And there's a 2, it's like I'm very clear, I just want to live a superficial life and I'm ulcerated, but I have a raised well-defined margin, so it is ulcerative with well-defined margins which are raised. And now we have more ulcerative, but it has not well-defined margins. It has infiltrating margins. Okay, it is infiltrating margins. To ulcerated with infiltrating margins, not well-defined. Okay, now the next one is purely infiltrating. That is, this one is the purely infiltrated. It has no ulcer. It's a very clear one. It's a very secret one. So non-ulcerative, purely infiltrative. And this clever one will give you most of the questions in your university, Viva, and everything in your OSCE exams also. So it is basically diffuse variety. On histopath, it will show signet cells, and it is also known as linitis plastica. So I'll explain all the things that how we came to the linitis plastica. For this, I'll now tell about the gastric CA. How are we dividing it? The most common is the adeno-CA. It is approx 90%. Okay, now in adeno-CA also, there are two types, type 1 and type 2. So here I'll tell you a story. The type 2 is most common in the females. Okay, the type 2 is the most common in the females, and it is a rare one. So if you will see India, in India, female has a lesser number, that is the sex ratio is less. Okay, so females are less. Okay, so it's a rare one, and the type 1 is more common in the males, and it is most commonly seen. Okay, first of all, I'll tell you the one more question. The gastric cancer, the most common is not familial, it is a sporadic. Okay, most common is the sporadic one. Okay, now the type 2. In type 2, I'll tell you a story that for a family you need a female. For a family to diffuse your family, you need a female. So it is seen in familial cases, and it is more diffuse, and everyone needs an alpha female. So like alpha male, we need a blood group of alpha. It's more commonly seen in the A blood group, and you have CTH1 gene mutation here, which is a E-catenin, and P53. Okay, the C-catenin gene is also seen in breast, which is lobular breast cancer. Okay, so this was one connection here from the other topic. Now the other one is the metastasis. How it gonna metastasis is by the direct route or by lymphatic. So indirect and lymphatic, it will diffuse, and this diffuse one will produce this linitis plastica appearance. Okay guys, I hope I can connect the dots now. You can connect the dots now that this is a type 2 one, which is more common in the female, and this type 2 is the rare one. This type 2 is the rare one. It is seen in the familial diffuse blood group A वालों में, and CDH1 gene mutation is seen in this case, which is E-catenin and P53 mutation, and metastasis by the direct or lymphatic spread. Diffuse it will spread and will form a linitis plastica, which will show a signet cells. Okay, now the type 1, which is most common in the males, type 1 which is more common in the males, and it is the most common adeno-CA type 1, but the most common gastric CA is by the sporadic one. This is the previous year question. Okay, so type 1 we'll call it a intestinal one. Okay, and in this we will see a blood metastasis, and there will be, if there is blood metastasis, then there will be gastric atrophy, which will be well defined, and there will be well differentiated ulcers, not like a diffused ulcer. It has the well differentiated ulcers. And in type 1, if I'll see the genetic part, or I would say the problem, which is the microsatellite instability, B-catenin, remember this B catenin and E catenin. Don't get confused between the B and E, okay? We can also remember it as a cross mnemonic, the type 1 and type 2. 2 is B, but 2 is here, and type 1 is E, okay? So the cross mnemonic you people can remember for catenin. Now this beta catenin, we have APC mutation also. APC mutation also, which is WNT mutation. It is also BCAT mutation. Okay. And also we'll see BCL2 mutation in this. So these are some important points regarding the gastric CA. I think the most important high points, I'll discuss it again in short way. For gastric cancer, we'll do the staging, TNM staging. For TNM staging, the best is the PET CT. It's better than the CCT because PET CT हमें metastasis बता सकता है अच्छे से. After metastasis, it will show about the nodal staging and the tumor depth. Okay, and ये भी more accurately हम लोग endoscopic ultrasound से कर सकते हैं. ठीक है. Now the staging, TIS. First the TIS is the high grade dysplasia. T1A is the muscularis mucosa. T1B is the submucosa, and these three are the mucosa and the submucosa with or without nodal staging, it doesn't matter, is the early gastric CA. For this we have the Japanese classification, and then the muscularis propria is in the T2. T2 will show the muscularis propria and T3 will show the adventitia. T3 will show the adventitia. T4A and T4B will show the adjacent structure, which is unresectable in T4B, and T4A is the resectable one, that is the diaphragm and the pericardium. Okay, apparently better. Okay, now these are known as the late gastric CA, which has the most risk for the vascular invasion. Now for these, we have the Borman's classification. Borman's classification tells about how are these, like polypoidal, ulcerative, or the non-ulcerative. So the polypoidal one will form a polyp, small polyp, and it is type 1. Okay, it is type 1, it is type 2, and this is type 3, this is type 4. So the polypoidal one is the type 1, and the ulcerative with the clear raised margins, you can see the clear raised margins, and is a type 2, and then the margins are infiltrating, that is the clever one, that is the infiltrating margins, which is ulcerating also, and it has the infiltrating margins. This is the type 3, and the type 4 is the very very clever one, which is not ulcerating and purely infiltrating. It silently infiltrate your okay, and this is known as the diffuse one. On histopathology, it will show the signet cells, and it is known as the Linitis plastica. Linitis plastica. So how can we connect that? This diffuse one come from the type 2 one. Okay, type 2 adeno-CA of the gastric cancer, type 2 adeno-CA, which is seen in the females, which is most rare cause, which is the type 2 is the rare one, and type 1 is the most common one, which is seen in the males, and it is seen the familial cases, and it is diffuse and blood group A. CDH1 gene mutation will be seen. CDH1 gene mutation is also seen in the lobular breast cancer, and in this you can see the E catenin. How we have remembered E catenin, B catenin, B catenin, E catenin. B is not gonna be seen in type 2, it's gonna be seen in the type 1. Okay, and E1 is gonna be seen in the type 2. This is how you can remember it. And now the meds, in the meds it will go from the direct spread. भाई इतना नहीं वो होता कि ब्लडी मैट्स हो रहा है मम्मी के अंदर, मम्मी को इतना नहीं आता भाई, मम्मी सीधे से डायरेक्टली स्प्रेड हो जाती है या फिर लिम्फेटिक स्प्रेड करती है. ठीक है, एंड देन विल शो द डिफ्यूज एंड लिनिटिस प्लास्टिका. ठीक है. Now in interstitial, the type 1 is the interstitial one. It's spread with the bloody meds. It is a well defined. It will show the gastric atrophies. Okay, it is well defined. It will show the gastric atrophy, and the mutation that we are going to see in this is the beta catenin, microsatellite instability, APC and WTN. APC, WTN ये सारा एक ही basically मामला है. APC, WTN and beta catenin. So these all you will see in this. So here's it, guys. Thank you very much.